Good afternoon. I'm Dr. Randall Morgan, and I have the honor of being the president and the CEO of the W. Montague Cobb NMA Health Institute. This institute was established by the National Medical Association in December of 2004 at Howard University, named for the distinguished professor of anatomy at Howard University, Dr. W. Montague Cobb. In spring of 2005, I was asked to serve as the executive director, interim, in 2005. And I was able to do enough to keep the job, I guess, and so now I'm president and CEO 21 years later. But this has been a very exciting journey, and we from the beginning had symposia that discussed cutting-edge topics in health disparities and health inequities. The programs are available online. We have a whole program booklet of the Cobb Institute that is available so that you can in-depth appreciate the faculty and the other programs that are occurring. But we're going to try to keep introductions to a minimum because we have a very full program today. The program is entitled Health Justice and Equity, a National Consensus on Racism and Health, and is with the partnership of the Cato T. Lorenzen Institute for Regenerative Engineering at the University of Connecticut, and sponsored by the Robert Wood Johnson Foundation. And building on a decade of national efforts, including the National Academy's consensus work on representation in medicine and UConn's 2017 Symposium on Racism in Medicine and Health, this convening will advance a shared vision for health justice. Through our keynote remarks, as well as the remarks and observations of our panel, we will examine historical and structural roots of racism, its impact across institutions, and the life course, and evidence-informed strategies for advancing health equity through leadership, organization change, and systems-level action. The objectives today will be to define and distinguish health equity and health justice, to explain how structural racism is experienced across the life course, identify intersectional and anti-racism strategies to address health inequities, and finally, to apply evidence-informed clinical, community, and organizational and systems-level strategies to advance health justice. To begin our program today, I would like to introduce to you our first speaker, who will speak on framing the challenge, health justice, equity, and national priorities. And this will be given by Iola Carlton, the Program Officer for Leadership and Better Health with our sponsors, the Robert Wood Johnson Foundation. Ms. Carlton.
Well, good afternoon, everyone. Thank you to the National Medical Association, the W. Montague Cobb Institute, and the organizers who brought us together today. It is an honor to be gathered in the legacy of Dr. Cobb and to be in community with health professionals, students, leaders, and those whose collective work has helped shape and continues to shape the course of American medicine. I also honor the generations of Black physicians, scientists, educators, and activists who built institutions when they were excluded from existing ones, who created pathways when doors remained closed, and who understood that medicine is more than the treatment of disease. Medicine is about dignity, justice, freedom, and the fundamental belief that every person's life has equal value. This conference bears witness to a truth that many of us know deeply. Progress has never been inevitable. Every gain we celebrate today was achieved because someone organized, advocated, challenged power, and refused to accept the status quo. In that spirit, I want to speak honestly about the challenge before us, and more importantly, the opportunity we have to meet it. Although every person's life has equal value, our nation's policies and practices do not always support that fundamental belief. And recently, we have seen increasing challenges to it. At the Robert Wood Johnson Foundation, we are working to ensure that every person in our country has a fair and just opportunity to achieve their best health, regardless of race, income, geography, disability, or any circumstance that has historically limited opportunity. We are tackling some of the most persistent barriers to health, specifically structural racism and other forms of discrimination as the root cause of most inequities. We are also protecting democracy so that people can shape the policies that affect their lives and their well-being. As a program officer, I am part of a team that invests in a strategic approach that is essential to this vision: leadership. Not leadership understood solely as position or title, but leadership as the capacity to organize and mobilize people, shift narratives, build relationships, create accountability, and advance collective action toward a shared vision. Lasting change has always depended on leaders who can help communities imagine a different future and help build them. For those of us working in health professions, education, and academic medicine, which is the focus of my leadership grant making, this work is inseparable from diversity, equity, and inclusion, and belonging. Yes, we can say the words. We cannot achieve equitable health and healthcare systems without addressing who enters, who advances, who leads, whose knowledge is valued, and whether institutions create environments where all people can contribute, belong, and thrive. The pursuit of equity requires us to transform not only healthcare delivery systems, but also the educational and professional ecosystems that prepare leaders who shape them. It is through that lens, one grounded in leadership, collective agency, systems transformation, and health justice, that I want to reflect on what RWJF and our partners have learned, where we must go next, and why every leader in this room is essential to getting us there. For more than 4 decades, RWJF has invested in advancing diversity in the health professions through scholarship and fellowship programs, leadership and mentorship initiatives, and professional development opportunities. RWJF has cultivated generations of physicians, researchers, educators, and leaders. Many of you have been part of that story. Those investments opened doors, expanded opportunity, and changed lives. They strengthened the health professions and academic medicine. Over the past several years, we have also engaged in a period of reflection. We've had to ask ourselves a difficult question. What happens when we diversify leadership but leave underlying systems unchanged? We learn that representation remains necessary, but representation alone does not transform systems. Placing individuals into institutions that remain fundamentally inequitable can unintentionally place the burden of change on those most affected by injustice. We learn that leadership without authority is fragile. Leadership without protection is exhausting. Leadership without collective support is isolating. And leadership without power rarely produces lasting institutional transformation. These lessons informed a fundamental evolution in our work. Today, our goal is not simply to help individuals navigate inequitable systems. It is to advance an explicitly anti-racist health professions ecosystem by shifting power and strengthening collective leadership in service of system-level accountability for diversity, equity, inclusion, and belonging. So what does that mean? That means moving from individual advancement to ecosystem transformation, from isolated excellence to collective leadership, from disconnected efforts to coordinated action, from representation alone to accountability and systems change. Most importantly, it means recognizing that sustainable change requires both inside and outside strategies and healthcare systems working together. It requires leaders working inside institutions to challenge inequitable policies, cultures, and practices. And it requires students, advocates, community organizations, legal experts, professional societies, and social movements working outside institutions to create accountability and pressure for change. History teaches us that meaningful systems change almost always happens when these forces move together. One of the most important insights shaping our work today is that systems are not sustained solely by policies. They're sustained by narratives. Narratives shape beliefs, beliefs shape norms, norms shape behavior, and behavior shapes systems. This has become increasingly clear in the current environment. We see how narratives about merit influence who is perceived as deserving. Narratives about professionalism influence who belongs. Narratives about race and equity influence public support for policies and investments. And narratives about individual responsibility often obscure structural barriers. This is why narrative change is a central component of our strategy. We are investing in efforts that challenge harmful assumptions about merit, expertise, professionalism, and belonging, while advancing narratives rooted in dignity, equity, accountability, and shared responsibility. Because if we cannot change the stories people believe, it becomes extraordinarily difficult to change the systems those stories justify. And if we want equitable and accountable healthcare systems, we must first create the conditions for people to imagine them. As I mentioned earlier, leadership is an essential strategy for achieving our vision. For many years, leadership development has focused primarily on preparing individuals to succeed and lead. That remains important, but the complexity of today's challenges demands more. No single leader, institution, profession, organization, or funder can transform systems alone. The challenges are too interconnected. The power structures are too entrenched. And the resistance too coordinated. One must therefore know that our response must be equally coordinated. At RWJF, we increasingly think about leadership not simply as an individual attribute, but as a collective capacity. The ability of people to build relationships across differences, to align around shared values, to develop shared analysis, to act together toward common goals, and to remain accountable to those most affected by inequity. That is why we are supporting collaborative leadership initiatives and convening spaces across the health professions ecosystem, including efforts such as the Roundtable that create opportunities for shared learning, relationship building, collective problem solving, and coordinated action. We're also funding minority-serving institutions, including HBCUs, to build their collective power. When leaders are connected to one another, they gain more than ideas. They gain solidarity and strategy. They gain protection and courage. And perhaps, most importantly, they gain collective agency. The shared belief that together we can shape the future rather than simply react to it. This work is more than about just improving educational environments. Health professions education is not the destination. It is the pathway. The real question is whether our institutions are preparing future health professionals to recognize inequity, challenge harmful systems, partner with communities, and lead differently. Are we preparing health professionals who can identify structural drivers of health, leaders who can transform organizations, clinicians who understand accountability to communities, future decision makers who can build institutions worthy of public trust? If we prepare them well, then our impact extends far beyond educational settings. It shapes care delivery, organizational culture, and public trust. And ultimately, it creates equitable and accountable public health and healthcare systems. So where do we go from here? I believe this moment calls us to reject despair and complacency. Despair assumes nothing can change. Complacency assumes change will happen on its own. Neither is true. We look to the history of the NMA, of civil rights, of public health and healthcare, all of which teach us that progress has never been inevitable. It has always been organized and relational, dependent on people willing to build power together. So as we leave this gathering, I want to offer a challenge. Continue your leadership, considering it a collective endeavor rather than an individual pursuit. Continue building relationships across professions, institutions, communities, and movements, and strengthening the infrastructure necessary for coordinated action. Continue developing narratives that affirm dignity, belonging, justice, and shared responsibility. And continue creating the conditions where future generations of health professionals of all backgrounds can thrive. Even though we are living through a period of unprecedented disruption, know that disruption creates openings. Openings for new imagination, new alliances, new forms of leadership, a new generation of collective action. The question before us is not whether we understand the challenges. We do. The question is whether we are willing to build the power necessary to meet those challenges. The moment is calling all of us, medicine, public health, philanthropy, academia, advocacy organizations, and communities to work together to build a more equitable and accountable health professions ecosystem. Not because the work is easy, not because success is guaranteed, but because future generations deserve better. Future physicians deserve educational environments that prepare them not simply to navigate unfair systems, but to transform them. Communities deserve health systems that are accountable to their needs, experiences, and aspirations. And all of us deserve a future in which health is no longer determined by race, place, power, or privilege. And if we choose courage over fear, solidarity over isolation, and collective action over individual effort, then together we can advance the vision that so many before us fought to make possible. A future where justice is not aspirational, equity is not optional, and health is no longer a privilege, but a right. I am grateful that this work is already underway and in progress by many of you. And I'm excited that today's program is an opportunity to discuss ways to advance it. Throughout these conversations, I hope that you listen for 3 questions. What must we build? What must we protect? And what must we do together that none of us can do alone? Because the future of health justice will not be determined by what any one of us knows. It will be determined by what we are willing to do together. I look forward to learning alongside you today and hearing the ideas, perspectives, and connections that can help move forward our vision to transform health. Thank you.
Thank you very much. Excuse me. Thank you very much, Ms. Carlton, for that stimulating, challenging discussion. This is the third of 4 significant plenary sessions at the National Medical Association. The 4th will be on Tuesday morning with the Bloomberg Foundation and the Morehouse School of Medicine, speaking about wealth in our communities and the survival of our communities. But to have the encouragement that Robert Wood Johnson Foundation has given to many of us, and certainly as an organization, the National Medical Association, at a time when encouragement is so important. We just thank you for coming and spelling it out for us and giving us a roadmap. And we're hopeful that we learn more specificities today about that roadmap through our panel and our other speakers. So thank you so much for the support today and the vision. Our next perspective will be given by Sir Cato Lorenzen, MD, PhD, who I know fairly well. We've worked together with the Cobb Institute since its inception. He is a university professor and Albert and Wilda Van Dusen Distinguished Professor of Orthopedic Surgery, a professor of Chemical and Biomedical Engineering, Material Science, et cetera, and the Chief Executive Officer of the Cato T. Lorenzen Institute on Regenerative Engineering at the University of Connecticut. He's also the founding director, chairman of the board of the Cobb Institute, and serves as the executive editor of the Journal of Racial and Ethnic Health Disparities. Dr. Lorenzen, please share your perspective.
Well, thank you, and good afternoon, everyone. So I was given the opportunity, and I'm very proud to be given the opportunity to share some of my perspectives about various aspects of the Cobb Institute and also this meeting. And I'm going to roll my first slide. So I'm giving perspectives on Cobb, actually on W. Montague Cobb and the Institute, the journal, the roundtable, and also the future. These are some of my disclosures of companies either own or receive royalties for. Well, first of all, I'm very proud that this day has come where we have the Robert Wood Johnson Foundation W. Montague Cobb Symposium. These are organizations that are both very near and dear to me, and to see them come together and work together in this type of manner, focusing on health justice and equity, which a national consensus on racism and health, and really start to have the conversations that we need about health justice and equity and how systemic racism, institutionalized racism can influence those areas. So for me, in terms of my personal perspective, I can summarize this by it was all a dream. And the dream actually started in many ways, with W. Montague Cobb. So earlier this year, and so W. Montague Cobb, this is actually a picture of him, and this is actually how I knew him, because I met him when he was in his early 80s. And he was a physician and an anthropologist, and he always spoke about the fact that he was an MD, PhD. And in fact, he was really proud of the PhD part, maybe even more than the MD part. And so he would always talk about that. And so I'm very, very proud to come in the line of W. Montague Cobb over time. Earlier this year, I was nominated for something called the W. Montague Cobb Award. Now, we have one here at the National Medical Association, but as you may know, or may not know, Dr. Cobb was a real activist at NAACP. And this is offered by the NAACP, and it was just established to honor individuals and organizations who've made an impact on the field of health in recognition of the extraordinary work of Dr. Cobb, who was the president of NAACP for a number of years. From 1976 to 1983, he was the president. And it's given, the national award is given to an individual by the NAACP National Health Committee in recognition of achievements in areas of health and social justice and advocacy, health education and promotion, or research. And so I was very honored, actually this week, earlier this week, to receive the award, to receive the W. Montague Cobb Award. Thank you. And in my talk, it was interesting. I thought my life had really come full circle, because to be able to receive the award and named after someone who had such an influence on my life was really important. So I wanted to share some of my remarks to you. First, I told him I'm proud to receive the National W. Montague Cobb Award, and that my life in many ways, this is my acceptance speech, has paralleled that of Dr. Cobb. Now, Dr. Cobb was a great scientist. I'm the father of the field of regenerative engineering, and I'm proud that just a few years before I received the Spingarn Medal from the NAACP, declaring me the foremost engineer, physician, scientist of the world. Dr. Cobb was a true pioneer in social justice, and if you look at his life and the sorts of things he did, the sorts of ways in which he went out of his way in terms of social justice, it's important. I'm proud to be the founding editor of the journal, as was in chief of the Journal of Racial and Ethnic Health Disparities, which is the leading journal in the field in the world. I received the Herbert Nickens Award from the AAMC for social justice and fairness. And of course, I've been the founding chair of the Roundtable on Black Men and Black Women in Science, Engineering, and Medicine of the National Academies of Science, Engineering, and Medicine. W. Montague Cobb is one of my heroes, and clearly has been one of my inspirations. So I met Dr. Cobb as a first year at Harvard Medical School. And I thought, first of all, it was remarkable that this larger-than-life figure would take the time to come just to speak to medical students during that time. From that, I've carried on his mentoring spirit in terms of talking to young people whenever they call. Dr. Cobb spoke of his accomplishments. He was unapologetic about his greatness, which I think that young people need to pay heed to. He was unapologetic about the great things he had done. He spoke about how having both an MD and a PhD prepared him for greatness. Dr. Cobb was bold, he was assertive, and he had an intention. That's what I said earlier this week. In today's terms, he had drip. And for the older people, that means he had confidence, charisma, and swagger, just to let the older people know. My life changed after hearing him speak and shaking his hand. Following his advice, I graduated from the Harvard Medical School, but also went to MIT at the same time and got my PhD. And when I co-founded a new institute on health disparities with the National Medical Association 20 years ago, they asked me what I wanted to name it. That was easy. I said, name it after Dr. Cobb. Today, the W. Montague Cobb NMA Health Institute is a vibrant organization in the spirit of Dr. Cobb. So I thank the NAACP for bestowing this award upon me, but more than that, I thank the NAACP for remembering Dr. William Montague Cobb, the icon. So those were my remarks there. So again, this symposium is really a coming together of organizations really dedicated in a true north way to areas of health justice and equity for Black people. The Cobb Institute has been incredible under the leadership of Dr. Randall Morgan. It's true, which he didn't say at this time, that I asked him to be the interim director at the end of 2004, just for a few months to get everything started, and that interim directorship has now lasted about 22 years. But he took the mantle and has done just a splendid job. So we were launched in December of 2004 at Howard University. These are some of the milestones that have been compiled, and it's just wonderful to see how the journal how the Cobb Institute has progressed under the leadership of Dr. Morgan. Our mission that we identify very on is to focus on identifying issues and developing solutions that will reduce racial and ethnic health disparities and, of course, improve the health of all Americans. And the Cobb Institute has had steady growth and steady leadership over these years, but also really thinking about W. Montague Cobb in the spirit of W. Montague Cobb in terms of his work both as a physician, an educator, and also an activist. We launched the Journal of Racial and Ethnic Health Disparities, which launched in 2013. I'm proud to be the editor-in-chief. Managing editor is Dr. Randall Morgan. It's been really a splendid odyssey in terms of our moving the journal forward over we're now in our second decade. This year we'll have over 1,500 submissions in terms of the journal. And last night I went on to Dr. Google and I said, Dr. Google, what is the greatest, best journal in racial and ethnic health disparities in the world? And Dr. Google replied, the leading and premier dedicated publication in this field is the Journal of Racial and Ethnic Health Disparities, published by Springer Nature. So it's got to be true. The other areas that we've explored is really is our World Congress on Racial and Ethnic Health Disparities. And this, we just had our second. We're launching our third is in December. And this brings together people from around the world working in the area of racial and ethnic health disparities. This is the group from January of earlier this year. It's grown every year. We're going to have the World Congress 3, or WC3, that will be again in St. Lucia, and we'll have information to the NMA in terms of people who want to join. It's a small meeting where we get together, we discuss, we use Chatham House rule, and we do publish the proceedings of this in the journal, and it's been really successful. Our sponsors, of course, are Springer Nature, sponsors the journal, and also the W. Montague Cobb NMA Health Institute. We've had the Roundtable on Black Men and Black Women in Science, Engineering, and Medicine. We started the Roundtable really because of the critical need that blacks make up 13% of the U.S. population, but only 4% of U.S. doctors. And there was a critical area in terms of black men. At the time, in around 2015, the numbers of black men in medicine had reached probably the lowest number since the early 1900s. And we created a workshop, which was it's a joint workshop. It's interesting if you look at the top, it's a joint workshop. When we first went to the national academies and said we wanted to do this, they said, great, how are you going to pay for it? And so we have to pay for our own workshop. And so the W. Montague Cobb NMA Health Institute with some other partners actually put in the first money. I said, we're going to have to make it clear then, if we're going to do it this way, we are a joint workshop with the W. Montague Cobb NMA Health Institute if we have to pay this to be able to have it. And then we published it in 2017, 2018, and with the help of the Congressional Black Caucus, We were able to have the creation of the roundtable in 2019. It's been incredibly successful. We've had a number of proceedings books, I think 11 altogether now at this point. And if we look at the ranking of these books, they're all in the top 10 to 15% of the national academies in terms of their downloads that are there. We had a hurdle year in 2025 after where we went through a strategic planning process to look at the future. We at first were very, very excited because in Science Magazine, the president of the National Academy of Sciences said that she pledged continued support no matter what would happen at the White House to the roundtable on black men and black women in science, engineering, and medicine. However, later, when we confronted them about, we've had proceedings of our roundtable, 6 of them, that have not been produced, and we need to have them produced. We had to have a come to Jesus discussion with the presidents of the national academies, and we told them that they've retreated from their publishing of these proceedings of the workshops. It's our belief that not publishing these workshops makes the national academies complicit in supporting a culture of racism and inequality. And we did it as an open letter to the presidents of the academies. And so they did respond, and their response said, we're a federal contractor, and so to continue our engagement under the present administration, we have made a decision to sunset programs, and the organization will not move forward with publishing any of your proceedings, and the roundtable will not be renewed in its present format. Interestingly, if you put in roundtable on black on the internet, our roundtable is still there on the National Academy's website, and you can still find the roundtable still listed on the National Academies. So it's a little bit of it's almost like this legend of Ricky Bobby. I'm not quite sure what the tactics are here in terms of that. The interesting, ironically, is there's a little tab that says work with us that you can click. And when it says work with us, looking for independent, nonpartisan guidance from the nation's top subject matter experts, contact us. Okay, all right. We'll see what ends up happening. So what's next in terms of the roundtable? We have conversations now with the new leadership of the National Academy of Sciences is ongoing. Obviously, they've got some issues now, battling over climate change, and so we're having discussions. We've reached out to other organizations that are aligned with our mission in terms of that are there, and we're working with our funders to continue our achieving our independent support for our work with the roundtable. We're very heartened by the fact that the roundtable on black men and black women in science, engineering, and medicine has just a tremendous reputation. We've been very, very productive. We have a 5-year impact report that can be downloaded that talks about our work, and we've had just a tremendous, with all our books and proceedings, we've had a tremendous impact in that area. And so we know you never know how strong you are until being strong is your only choice. And these challenges that we have with the roundtable, people say, my God, you've been being beaten up here. No, these challenges are opportunities. The roundtable will come out stronger, better, and we have to, in many ways, we welcome these challenges because in the end, it'll make us better. I want to close by thanking our anchor funders in terms of our roundtable on black men and black women in science, engineering, and medicine. It's never been popular to support black people. People say, my gosh, the present administration. Well, it's not been that great in the past administrations either. So it's never, but organizations have stepped up. The Aetna Foundation, Burroughs Wellcome Fund, but the Robert Wood Johnson Foundation has been incredible in terms of stepping up and supporting us from our beginnings back in 2016 when we first approached them about helping us with funding for our first workshop. Now it's it's now over a decade in terms of funding and support. At our peak, these were our funders: Burroughs Wellcome Fund, Robert Wood Johnson Foundation. But those two have been with us from the beginning, and they've stuck with us throughout this throughout the work that we've been doing. As you may know, we have a new grant with the Robert Wood Johnson Foundation, exploring multifaceted solutions that can increase and support Black representation in science, engineering, and medicine. It's a grant to the Cato T. Lorenzen Institute for these activities. And our goal is to really partner with stakeholders around the country in terms of these issues and these hard questions that have to be asked. The paragraph that's most important about our grant is by addressing both institutional policies and having community engagement, and by leveraging a broad network of constituents, the project aims to create comprehensive and sustainable change in the representation of Black individuals in science, technology, engineering, and medicine fields. This is a very, very important part. This symposium is a very, very important part of our commitment to moving forward in that area. And again, I want to thank the Robert Wood Johnson Foundation for not only supporting and providing the funding, but being here and being a part of this symposium that's there. Thank you very much.
Thank you very much, Dr. Lorenzen. As I sat and listened to Dr. Lorenzen's talk and also that of Ms. Carlson, it's apparent the impact that the Cobb Institute has had and the history of it all. And in fact, the Institute was established, the idea was established within the National Medical Association by two of our past presidents, Dr. Rodney Hood and Dr. Gary Dennis. And in their work at the around 2000 mark, that led to the National Academies of Medicine establishing a roundtable which eventually published Unequal Treatment in 2003. And so NMA then took the initiative and formed the Cobb Institute. So it all comes together, except even more so comes together because our multiple awardee for the Cobb Institute last evening, Dr. Georges Benjamin, who received the W. Montague Cobb Award, and is also the executive director of the American Public Health Association, was one of the authors of Unequal Treatment and recently completed a 20-year review, which I read cover to cover, which really explains the pitfalls we've had as a Cobb Institute from getting to A to B as the definitions have changed, the goalposts have been removed, and I thought eloquently stated in the summary of that document. So I would strongly recommend that we go and review that document from the National Academies, I think it's 2024, on a 20-year review of unequal treatment, because it's parallel to the strategies that we have had and the importance of what the National Medical Association contributed back in 2004. Dr. Georges Benjamin today is our Cobb lecturer. This symposium began in 2008 in Atlanta, Georgia, and the first lecturer was Dr. Augustus White, the distinguished professor of orthopedic surgery at Harvard, and it was on cultural competence. We've every year since that we've had a lecturer, and several times we've had the lecturer to be also the recipient of the W. Montague Cobb Award. Dr. Joan Reed, who you'll meet later, is one of those past lecturers. So your bio was presented last evening, you were presented last evening, so we're presenting you today to the symposium. Please come and give us your wisdom. Dr. Georges Benjamin, our lecturer today.
Well, good afternoon, everyone. This is going to be a conversation about the resistance. We talked about whether we should have data and talk about equity and where we need to go, and I thought that would not be useful for a group of people who could probably sit me down and teach me that stuff. So with that in mind, I want to remind us, because I often get asked as a physician, why should I not stay in my lane? And I just remind you that my lane is, if it hurts people, it kills people, is ours. So with that in mind, I remind you I have no financial disclosure or conflicts of interest with today's presentation, but I do have a bias, policy bias I want to share with you. There's no question I am pro-health and pro-science, and I have proudly carried that bias wherever I go. And you should take what I say today with that context and that bias in mind, and I do that with no apologies whatsoever. I also want to pay homage to Dr. Cobb, who I also had the opportunity to meet and used to hang out with in the Howard Suite as a young physician, listening to his wisdom. As those of you who knew him, he was clear, concise, authoritative, and ethical, knowledgeable. And he's real clear about the fact that it's not about biology that determines one's place in society. It's the circumstances in society that determines their biology and their status. And I want you to think about that, because we talk a little bit about social determinants, and as an ER doc, it was very painful for me to recognize that 80% of what makes you healthy occurs outside the doctor's office, but it's true. It's true. So I think as we think about our conversation today, I want you to just think about Dr. Cobb and what he would be doing today if he was advising us today. So this is a conversation about the resistance. So I'll remind you also that physicians have a historical role in creating our new nation. It ain't new. There were at least 4 physicians who signed the Declaration of Independence. At least 4. There's a debate about a 5th who were involved. Only one of them had been professionally trained in medicine. But in those days, lots of people got into this business through apprenticeships. And of course, that was Dr. Benjamin Rush, a very firm abolitionist at the time. Questions about the fact that he promoted leeches as part of his therapy, but we learned lots of science in medicine. And also to remind you that the United States is a democracy. It's one where our citizens elect officials to represent our interests in government, which also means that we're also a constitutional republic. And that means that the power is derived from the people, but exercised through elected representation under the rules fundamentally of the U.S. Constitution. And this Constitution limits government power and strives to protect individual rights. Like all documents, you have to make it work. It doesn't just happen naturally. But fundamental to this system are principles of equity, the rule of law, and citizen participation through voting. So I always think of voting as a health intervention and other civic engagement. And democracy, of course, represents a broad civic culture where we have a voice. And ultimately, we have the power, but we have to exercise it. If you lay down and don't vote, if you don't engage, then you get what you get. So you have to be part of that process. And our founders created a divided government because they had seen what happened through the king and wanted to distribute that power in a variety of ways. And conceptually, even though they fundamentally didn't trust one person, one vote, voting was clearly the way that they felt it was important for us to express ourselves and express what we thought was important as citizens. Now, as citizens, we rely on a lot of structures, juries and voting and engagement, being on the school board, things like that to help guide what we do. And we do this through advocacy. And I just want to remind you that physicians, don't lose your voice. You have the opportunity to be advocates. You advocate for your patients each and every day. Don't just think about advocating for that individual patient, but advocate for the health and well-being of your communities. And in order to do that, you have to do that through participation of public health efforts, talking to your legislature, getting outside what folks think should be our lane in order to do that. Now, public health is fundamentally foundation of the civic well-being, social stability, and the resilience of our communities. And we must be active participants in this civic dialogue and not silent technicians. And that's a challenge because a lot of folks that go into governmental public health in particular often want to be the technicians but don't want to speak up. And I encourage my colleagues not to do that. Of course, also our facts ought to be driven by science, evidence, and data, our lived experience. That lived experience is important. Science and medicine is an art and a science. But all these things interact to shape fundamentally healthy communities. And public health, by law, is the one entity that has the core responsibility for population's health. The 10th Amendment gives us that responsibility because it gives us police powers at the states and by derivative to the governmental public health entity, and then by derivative to those entities we partner with or collaborate with to improve the public's health. Federal government can play an overlay on that, but this is fundamentally a state responsibility, and by nature of that, the people that are responsible for the health and well-being of their communities. So when I say it helps people or kills people is mine, that's the framework in which I'm coming to you to share that viewpoint. And we've been at this for a long time. We've been on this for a long time. I remind you, in 1799, Boston established the nation's first Board of Health. And the first health officer in our nation was a young man by the name of Paul Revere. Now, he wasn't a doc, but okay. But he was certainly the nation's first health officer, and he was an activist health officer in many ways back then. So we've been at this since our nation's founding. And these are the 10 essential services for public health who don't recognize this figure. And I want to point out that equity is in the center of public health practice. That's important. Because if people try to pull the rugs from the conversations around equity, it's impossible. It's part of our being, part of our core. Justice and health is fundamental to ensuring health and wellness of our communities. And our health and public health colleagues together make that happen. And then there's Trump. So for the last year and a half, we have been challenged by a health policy that has done several things. In many ways, tried to reform a healthcare system in a way that limits access to care by cutting funding and limiting access for a range of services, going after things like gender-affirming care, reproductive rights barriers, limiting funding research for diversity, equity, and inclusion, but other things too, women's health, children's health, in a non-discriminating, abrupt way. By dramatically downsizing the government with no concept of what they're doing, and reducing our engagement in the world. And we've already seen the challenges and tragedies that have occurred because of the barriers to working with the World Health Organization, to eliminating USAID, and cutting funding for many of the global health programs in the middle of amazing outbreaks that threaten our health. And of course, now tariffs are just beginning to leak in to impact our supply chain, both pharmaceuticals, supplies, and equipment, because of some of the irresponsible tariffs that have been put in place that may not have been clear how they impact the health system, but dramatically will impact the health system. There will be days soon when we will again be rationing pharmaceuticals because we can't get them, because of changes in the supply lines, not just for the medications themselves, but for their component parts. And stupid things, like limiting our access to fluoride in our drinking water, inappropriate use of research studies. I mean, it's fascinating. I had a chance to review almost many of the reports that have come out by the department, and they're generated by AI, and not just any old AI engine, but one that hallucinates on a grand scale, references that don't exist. We even just recently had a call for funding from the federal government, which referenced the American Journal of Public Health. Some of you may know APHA is the publisher, and I serve as the publisher of the American Journal of Public Health. And we actually had references in this call for funding that referenced the journal that didn't exist. We, of course, let them know about that. But it's amazing what they're doing, taking things off the website, changing data, frankly, making their communications useless because you have to check everything. And some of the things, you know, they can't even get the spelling right. It's amazing. And this comes out of our federal government. And we're struggling, I think, in the public health field, trying to figure out how we support the agencies of federal government, because we know the people there and we know they're working very hard. At the same token, their bosses are screwing things up. And then amazing unscientific changes to vaccine policy, and as you may know, APHA has been part of the lawsuit of the American Academy of Pediatrics versus RFK to address some of the unscientific, abrupt changes they've done in vaccine policy. And at least so far, the judges has ruled to force reversal of those policies. It still needs to be mitigated on the merits of the case, but so far, things are going in a pro-health direction. I need to be very careful because this is in litigation, but it's an important lawsuit. You should pay attention to that one. And of course, the attacks on diversity, equity, and inclusion. I'm going to come back to that one. We've been talking about that a lot at this conference. The impacts on health of America is profound. I am pleased that APHA was the lead of a lawsuit which sued the National Institute of Health and the department, which forced them to reverse and give back the money for the grants for diversity, equity, and inclusion. But they just hit a wall and trying to do other things, trying to slow down, cut, undermine those efforts. But so far, the people that got their grants back are able to do the research. And then a whole range of discriminatory workforce actions under the guise of we're trying to be fair and want to make sure everyone gets what they want based on merit. And then this administration has amplified its aggressive, inhumane, unethical, immoral efforts against people who are immigrants in our country. Don't be confused, because they're not confused about what they're doing. They're not confused at all about what they're doing. And we need to put an end to this. We need to stop the concentration camps in our communities. We need to stop these fools with these masks and these guns, these murderers who are killing people indiscriminately. This needs to stop. This has to stop. So now what? You know, I've complained like I always complain and played a lot of problems. But I think the important thing is, as our government withdraws, it gives the opportunity for civil society organizations to fill the gap. And there are many organizations. National Medical Association has partnered with us on stuff, APHA, many of the other professional societies are now filling that gap. And I encourage you to be part of that revolution, part of that process, speaking up and engaging with all of our elected leaders. I had a chance to watch our president speak at Congress the other day, and sir, you spoke truth to power. And I was just so proud of everything that you had to say. And it certainly demands a much more proactive approach from those of us in public health. We can no longer be the nice guys, the gloves are off. So in summary, here's our advocacy approach. First of all, I would encourage you to make them follow the law. That's been the one barrier to stopping them for some of the things that they're doing. We can also make it visible because in the business that we're in, an action, and then there's a health event that occurs downstream, people are not real clear about connecting the dots. So we have to help them connect the dots. Fire outreach workers who are in the middle of a measles outbreak, more measles. Cut funding for disaster preparedness when a disaster occurs, inappropriate response, slow response. We need to help people connect the dots by being very clear about that. And then we need to do something that we have been really reluctant to do, is we need to name names. So we used to say, Congress did this, or Congress did that, or the administration did this, or the administration did that. Well, those days are over. We're now saying who did it, what their district is, who their constituents are, and we have no problems with that. By the way, you can do that as a C3. You can tell on people. That does not violate your C3 status. And of course, if they take it away, you just incorporate another C3 on the side. Don't worry about it. But we can do that. We can speak truth to power, and there's a reluctance to do that. As you know, when they first started coming out, people were very afraid of what they meant because it was the government doing what they're doing. But I think the most corrosive thing we can do is anticipatory obedience. They say something, we assume it's okay, and then we follow it. And in my lifetime, the most serious one has been this issue around diversity, equity, and inclusion. So first of all, I don't call it DEI anymore. I call it diversity, equity, and inclusion. And then I remind them that if you're not for diversity, you're for homogeneity. If you're not for equity, boy, you must be for inequity. And if you're not for inclusion, you must be for exclusion. And who wants to be part of that? At least it makes them pause and listen. And for me, that's a core value. And I would encourage us to maintain our core values. Go back to our mission statements. You heard that from one of the panels earlier today about mission, staying on mission, staying focused, stay with your core values. And at the end of the day, my dad taught me to have no fear. They only have the power that they are given, and if you give a mouse a cookie, they're going to want a glass of milk. And bullies always collapse when they're stood up to. And then finally, I love this proverb that says, until the story of the hunt is told by the lion, the tale of the hunt will always glorify the hunter. And the bottom line is, we should tell our own story, and we should reverse all this nonsense on DEI, because it is not illegal, it is not immoral, it is just, and it's the right thing to do. With that, I thank you, and have a wonderful, wonderful convention.
Thank you, Dr. Benjamin. You certainly did not disappoint. We're going to pivot now and have a very engaging panel. So while we invite the panel to take the stage and their moderator. Our moderator for the panel is Dr. Joan Reed, a professor of pediatrics at Harvard. She serves now as the Dean of Culture and Community Engagement at Harvard University. And she has been a part of many of the programs that Dr. Lorenzen mentioned earlier in terms of the National Academies of Science, engineering and medicine, and certainly has supported the Cobb Institute as a senior fellow, speaker, and honoree. Dr. Reed will introduce our panel, and we will proceed with a panel discussion. The summation of our program today will be given by Dr. Rogers Mitchell, President, 126th President of the National Medical Association. And so stay tuned. Thank you so much for your attendance.
Thank you. Thank you for being here today. I am Dr. Joan Reed, has been mentioned by the Dean for Culture and Community Engagement at Harvard Medical School. Since I've been here, I've been asked about my title. As you might guess, this is one of many titles I've held over time, and it's okay. The title will change again, but the work remains the same. And as we deal with this panel around structural racism and health, we have 4 wonderful speakers. I'm going to say a few words about each one of them to introduce them. They'll speak in sequence, and then we'll open it for questions. Our first speaker is Paris Atkins Jackson. Dr. Jackson is an assistant professor of epidemiology and social medical sciences at the Columbia University Mailman School of Public Health, and she will be speaking on the role of racism in medicine and public health, including life course impacts. Second will be Dr. Laura Morgan Roberts, the Frank M. Sands Associate Professor of Business Administration at the University of Virginia Darden School of Business, who will be talking about organizational leadership, diversity, and institutional transformation. Third will be Dr. Derek M. Griffith, the Risa Levizo-Mori Population Health and Health Equity University Professor in the Department of Medical Ethics and Health Policy in the Perelman School of Medicine, and also a fellow and senior advisor on health equity and anti-racism at the Leonard Davis Institute of Health. He will be speaking on intersectional and anti-racism approaches to advancing health equity. And then Tony Iden. Dr. Iden is the CEO of the Health Trust. We'll be speaking on place-based and system-level strategies to address structural drivers of health and advance equity. We're talking about things as they exist, but also turning to things that we can do from the individual to the organizational to the community level. And with that, our first speaker, please.
Good afternoon. My name is Paris Atkins Jackson. Please call me AJ. So this is sort of how I want to set up an understanding of structural racism in case you are not familiar. So we tend to start with that term structural, which is this system-level experience that sets the tone for everything that we endure. It sets standards, it sets rules for access, restrictions that then get practiced and implemented by various institutions in our society, healthcare being one. And you might experience that your institution has specific practices and policies that determine what then you can do with an individual who's coming in for care. After that interpersonal exchange, this trickles down into an individual level experience. And currently, the way we look at structural racism is there's 4 sort of biologized pathways. There's first the physical violence that might lead to injury, and then you have a myriad of conditions that can occur after that. Next to that, we have our traumatic experience that might cascade into internalizing symptoms of poor mental health, disrupted sleep that might lead to lack of lymphatic clearance that then cascades into a lot of brain health outcomes that we might see. But then you get to the one that we are most familiar with, which is stress. We tend to think of stress as sort of that first step or first response after a racist occurrence or a racist experience. That stress then evolves into, that hormonal disruption evolves into a pro-inflammatory environment in the body that could lead to things like allostatic overload. Now that overload, and in my area of aging and dementia, quickly gets us into lack of neuroplasticity, vascular issues with vascular integrity that just move ourselves into a mixed pathology of dementia, which is currently what we see a lot of. I know we talk about Alzheimer's disease, but often what we're seeing is a mixed pathology of dementia, which is why it's so difficult to pinpoint and deal with. I got notes, y'all, so I can stay on task because I'm getting old. I know y'all don't believe that, but I am. I'm officially midlife, y'all. Okay. So you might think of this historically or developmentally for an individual. So before birth, you're coming into a world with disproportionate economic resources, maybe farm ownership, land ownership. You're also coming into a very strong racial violence environment. And by early life, you're inheriting all those exposures and adding to that sort of issues with mobility that will continue into adulthood. So lack of access to adequate education or resources. In adult life, lack of access to home ownership or income or health care. By midlife, you've inherited all of those different exposures, and now some of the pivotal determinants you need are not accessible, like healthy food, like representation in your government that Dr. Benjamin talked about, like green space. All these things that at a pivotal juncture in your life course you really need are not accessible due to racism. And then if you manage to survive that, which many of us don't, but if you manage to survive that into late life, now you're dealing with the multi-generational risk that you're seeing future generations live the same life you barely survived, on top of the fact that either you or the society you lived in is now forgetting that you exist. I've spent the last 8 years of my life measuring this sort of historical developmental cross-section to really pinpoint moments of intervention, and I actually think I've gotten it wrong a lot of times. I think I've overspent time on measuring. I now want to spend the rest of the time that I have testing out interventions, because I think our communities have long done it right. Our crime reduction interventions, like my favorite one in Baltimore, has reduced the crime rate in Baltimore. Now let's see how we can leverage that intervention to reduce neural inflammation in our older adults. So that's life course aging and racism.
Thank you.
Thank you. It's an honor and a pleasure to be here. I am an organizational psychologist by training. I am the product of a family that is rooted in medicine and education. And I attempted to go purely the educational route, and that's not where I landed. I'm here right now in NMA, but I want to go back farther, actually, to the year 2000. I've been passionate about studying and understanding what I call Black leadership incubators since I grew up in Gary, Indiana. So I was born in Gary, Indiana. I was born, in Evanston, Illinois, grew up in Gary, Indiana in the mid-1970s. And at that point in time, Gary, Indiana was almost exclusively a Black community and really a test case for structural racism in terms of economic deprivation, increasing lack of workforce opportunities, lack of access to resources that would help Black communities develop health and wealth. And within that space, I was born into a family that was and still is deeply committed to creating thriving and flourishing for Black communities and beyond. So I, again, was very interested in the leadership questions as are currently being framed in such a powerful and visionary way by the Robert Wood Johnson Foundation. So thank you so much for that opening. And I'll share a bit of my personal experience as I believe it connects to the moment in which we live right now. So the year 2000, I was working on my dissertation at the University of Michigan. I knew from starting the program that I wanted to study diversity, equity, inclusion. I applied with a personal statement that said, I want to study diversity, equity, and inclusion, and I never wavered from that. However, when it was time for me to collect my dissertation data, I had an impossible time finding organizations that would allow me to come in and document experiences of racism and discrimination. because it benefits organizations and communities for us to continue to rely on a single story, a single episode, create narratives of inadequacy and unworthiness around those single stories and episodes that then justify the inequalities that exist within our workplace and that exist within our community and our society. So, you know, the data are a threat, a challenge, but also a powerful lever for institutional and social change. I had been granted permission to collect my dissertation data from a regional bank, which is now the largest national bank in the world, and led by the same individual who at that time was the CEO of the regional bank. Had green lights, green lights, green lights. General counsel caught wind of the research that I planned to conduct after it had been signed off on by everyone else, and then the next day I was out. So I had already defended my dissertation proposal. I thought I was on track to graduate as I had planned according to my timeline, and I'm sitting here with no data, no site, not knowing how to move forward at this point in my career. So, now I'm going to do what I'm not supposed to do, which is to give an explicit self-own, but I'm going to do it intentionally. So, my father, who, if you've not picked up on it yet, which some of you already know this, is Dr. Randall Morgan. And my older sister is here as well, Dr. Sharon Morgan Robinson, and my mother, my mom, the educator side, Karen Morgan. So they all knew that I was experiencing this moment of crisis, and my father connected me with the leadership of the Student National Medical Association, of which my older sister had also been involved. I went to NMA. I came home with all of my data for my dissertation. I defended my dissertation a few months later. The stories were so compelling that I was hired in my first faculty position as an assistant professor of business administration at the Harvard Business School. And I say that, you know, Dr. Lorenzen said that we need to be more explicit about our stories and our journeys. I don't say that as a source of personal pride. I say that from a point of humility as a 27-year-old Black woman at the time who had to rely exclusively on the village and specifically on those individuals who are in this room. Dr. Joan Reed has also been a powerful mentor toward me. So what I would say here around Black Leadership Incubators is that our next steps will be to continue to build with one another, to own our own stories, not allow our voices and our data to be erased. Don't shy away from the power of our networks, of our community, of our intergenerational mentoring. I've taught in business schools all over the world, and I can tell you in the executive leadership programs, we are not there. Okay, so the only way that we are getting this type of insight and development and the resources and encouragement that we need as leaders is from and through one another. And that's increasingly the case, as Dr. Benjamin just pointed out, in sobering detail in terms of the latest attacks that we are experiencing. So, you know, Bob Marley, I'll put my favorite one out there. Emancipate yourselves from mental slavery. None but ourselves will free our minds. And the first thing in that is just to let go of this idea that we have to do it on our own. We have to figure it out on our own. We have to prove it on our own. I'm so proud that every time I meet somebody from my hometown in Gary, Indiana, or if I'm walking around NMA and someone knows that I'm Dr. Morgan's daughter, that's not something I'm ashamed about. That's a source of personal pride. That, to me, is the vision that our ancestors had for us, and that's where we can continue to work while it's day in this moment of tremendous trial and tribulation.
Good afternoon, all. Oh, we can do better than that. Good afternoon. It's a particular pleasure and honor for me to be here. I'm the son of someone who was a lifelong NMA member, Dr. Patrick Griffith, and who was also a very proud grad of Howard University School of Medicine. I was born there, so this is a particularly special moment for me to be here. Let me also just say that the title that I have at University of Pennsylvania, being named after Dr. Risa Lavizzo-Mowery, I also don't take lightly as the first Black person and the first woman to be president of the Robert Wood Johnson Foundation. Is not something that I also take lightly at all. The third, I'm also quite a proud member of the American Public Health Association, and you heard from our fearless leader, and you know why we love him, Dr. Benjamin. He, even before these latest attacks, was very supportive of our efforts to publish 2 books, both called Racism, Science, and Tools for the Public Health Professional. And it has been APHA Press that has been instrumental in advancing that work and supporting that work. And actually, to one of the first points that I will make in transition to my remarks, as we think about even just his remarks talking about diversity, equity, and inclusion, and the importance of countering misinformation about what we're hearing and seeing, it's important to distinguish diversity, equity, and inclusion from health disparities. Those are not the same. Those are not equivalent. One does not go under the other. Diversity and equity and inclusion are about representation, opportunities within organizations, and so forth. Health disparities is about people's health and well-being and who has opportunities to be healthy and who has the opportunities to live well and long, healthy lives. We were able to publish a paper that describes these differences and challenge the administration in the American Journal of Public Health that came out earlier this year. So they have been, I stand 10 toes down with APHA because of the importance of how they've been able to stand behind these efforts and that work. But it is important for people to understand the difference between diversity, equity, and inclusion and the work that we're trying to do to achieve health equity are really fundamentally 2 different goals. And yes, certain folks have tried to conflate those, but we have to understand those are fundamentally different. Another key point that I just want to make is it's important that we understand, we typically focus on racism and obviously the adverse health effects of the structures that we're paying attention to. What we focus on less, and I think we need to pay more attention to, is whiteness. Whiteness is the study of who is benefiting from these systems and structures, not just who is being harmed by them. If you're not paying it, like people don't wake up necessarily trying to hurt somebody else. They wake up trying to hold and, hold power. And they're trying to hold privilege and hold opportunities that they haven't necessarily earned. And so unless you're understanding what are the things that people are trying to benefit from by creating this system of inequality and perpetuating a system of inequality, you can't understand how you're going to dismantle this system. By just focusing on the problem, we're missing it. We have to see who benefits from it. One of the framing questions that we were asked in a prep call for this meeting, for this panel, was about what could the NMA and the Cobb Institute do to address these issues. And I think you heard it in Ms. Carlton's remarks and a couple others. Partner. If NMA and the Cobb Institute could partner with APHA, with the American Public Health Association and various other groups, a concrete example was a few weeks ago, Dr. Benjamin and some others were part of a group that had the first conference on the mental health and well-being of Black men and boys. And there were 6 organizations, APHA, and various others. I'm not going to go through the list. But it would have been nice if the NMA Cobb Institute could have been part of that number and could be part of that number going forward. Couple other just basic points. The way that we tend to think about the poor health of black populations, we tend to look at it still in isolation and in separate issues. And one of the things that we need to look at is why are the poor health of black Americans clustering in black people? What I mean to say is if we look at patterns of whether it's heart disease, diabetes, dementia, accidents, they're all clustering in the same people in very predictable ways. What we haven't looked at is what is it about the shared experience of us that we would actually look at and help us better understand that. Racism helps do that, but there's a concept called syndemics that helps us do it by looking at the mechanisms, the biological mechanisms, and how that connects to the structural factors that would help us to in a more refined way, connect these dots and look at how those structural factors that Dr. AJ was talking about get into the body and to look at why those things are so predictably good markers of who's going to have poor health and who's going to die prematurely. Intersectionality helps with that as well, but it's also important to look at intersectionality through the lens of how it helps to refine the way that the populations are targeted and experience it. How black men experience racism and gender structural racism is very different than how black women experience it. And if we're going to address it, we have to understand how those two things are separate and differ and interact. The last thing I would say is somewhat of a more selfish thing, since I do a lot of work on black men's health, is I would love for the Cobb Institute to do something where they provide leadership on black men's health. There is no other institution, there is no other organization that is doing something that is on black men's health. I'm not saying it as a black man who wants to be healthier. I'm saying it as one who studies black men's health largely because nobody else is doing it. And if there were some leadership to be provided on how we better understand what are the unique structural conditions that have consistently had black men falling further and further behind black women, as well as their white male counterparts and every other group aside from Native American men, then I think that could be something that's an important model for how we actually think to address health inequities and how we achieve health equity. Thanks.
Well, good afternoon, everybody. My name's Tony Eiton. I'm the CEO of an organization in California called the Health Trust. Before that, I was the chief program officer at another foundation called the California Endowment, which in California, it's the largest health foundation in California. I want to talk about solutions a little bit because it's been sort of the central focus of my career. But before I do that, I want to talk a little bit about kind of how we came to the approach that we used and still use in California. I want to make a shout out to Dr. Rodney Hood if he's here. He's the reason that I'm here. And I got to know him working in California on what is still described as the largest place-based health improvement initiative in the history of the United States. It was called the Building Healthy Communities Initiative, and I got the privilege of being the principal architect of that. And I will tell you that that was one of the most exhilarating experiences of my life. And let me describe it for you a little bit. I was invited to come into a foundation that was planning to spend roughly $1 billion over a decade, focused on the social determinants of health, trying to improve the health status of communities that had been experiencing health disparities for many, many years. And there was only one caveat to the offer, and that is that I couldn't spend a nickel on health care. I had to find a way to do this entirely through investing in prevention. And so, you know, I was basically given a blank sheet of paper, $1 billion, and a decade to try to make measurable improvements in the health status of populations that had been experiencing health disparities. I'm going to talk to you a little bit about what that looked like, but first I want to describe to you how the thinking that went into the setup of this particular initiative came about. I went to medical school in the 1980s. I went to Johns Hopkins Medical School, and there was a cardiac surgeon there by the name of Dr. Levi Watkins. And he became one of my mentors. And he facilitated an opportunity for me to go to South Africa during apartheid to study the health of black South Africans under apartheid. So I did that in 1988. And I was in my 20s, and I lived in Alexandra, just outside of Johannesburg, in Soweto, in Khayelitsha down near Cape Town, and I got a deep, deep, deep understanding of what apartheid looked like in South Africa on health. I worked at Baragwanath Hospital, which is in Soweto. I worked at the Alexandra Clinic, and I saw the differences in the kinds of care that were available to black South Africans. But more importantly, I met black South African leaders. And there was a look in their eye, this sense of potential. They knew that apartheid was going to crumble, and that they knew that their future was to have political control over the country of South Africa. And there was a sense of, in retrospect, I didn't call it this at the time, but it was a sense of agency, a sense of potential. And it was a collective sense of agency, a power, that they could actually overcome this oppressive set of policies, politics, and practice. And that changed my life. I came back to Baltimore, to medical school, and all of a sudden I had a different way of looking at the United States. I recognized that the US was an apartheid country. And that's what structural racism is. It's physically separating people from opportunity, from decent health care, from decent housing, from decent education, from employment, from even access to things like potable water. And once you sort of see the United States that way, it changes how you think about what health disparities are. And I was frustrated by the fact that oftentimes when we talked about health disparities, we use this biomedical model, which is actually a narrative strategy to sort of blame the victim. It was about behavioral differences. It was about lack of access to healthcare or lack of compliance with healthcare, and it was about genetics. And none of those three things explain the major drivers of health disparities, and I had to prove that. So I set out to essentially do some studies. We did some analysis looking at life expectancy across relatively small geographical areas, and we were able to demonstrate that there were 20-year life expectancy differences across the same city, in multiple cities across the United States, and those analyses ended up on the front page of the newspaper. And I had to ask my colleagues, how do you explain 20 years of life lost across the same city? You can't explain it by genetics. You can't actually explain it by access to healthcare, and you can't explain it by behaviors. You can explain it by political power. And that's how we came to the conclusion that with our work in building healthy communities, we had to build social, political, and economic power in a critical mass of people living in these communities that were struggling with these health disparities. And that's what we did for 10 years. And we ended up spending almost $2 billion. And we continued it for 12 years because it was actually quite successful. It started delivering on meaningful policy change in California that was impacting the lives of people that were living in communities that were systematically deprived of some of the critical social determinants of health. And we concluded, and I joke about it, I say I spent $2 billion and I came away with one conclusion, that the solution to these problems, and we so often don't talk about the solutions, we talk about the problem, we don't talk about the solution. The solutions to these problems I describe as ABC. A is agency, just power. These are political problems, and they need politics, and I'm not talking about Republicans and Democrats, I'm not talking about partisanship. I'm talking about a definition of politics, which is the struggle over the allocation of limited and precious social goods. And those may be things like having a park in your neighborhood or a full-service grocery store or potable water coming out of your tap. Those are political resources that are allocated in political processes. And communities that don't have sufficient political power are much less likely to get an equitable allocation of those health protective resources. That's what structural racism is. It's making it less likely that you'll have access to the things that we all need to be able to live a healthy life. That's the A of ABC. The B is belonging. And belonging is really like the antidote to racism. It's about seeing your culture, your history, your story told across the communities that you live in, that you are seen as a vital part of that community. And you can build belonging in community, as we did in California, that had profound impacts on policy. And this is a critical thing that many people that are progressive, that are trying to improve health, forget. We get enamored of the policy. We forget the narrative. Narrative begets policy. Policy begets conditions. So B is belonging. And then C, I like to refer to it as the social contract. It's the agreement that we have to invest in each other and to invest in the future, primarily through policy. Some people just call it changing fundamental conditions. Rather than trying to change individuals, focus on changing the conditions that people are able to navigate in order to pursue a healthy life. And you can do that largely through policy, but not exclusively through policy. But if you can focus on that, you can make profound change in health disparities. So that's what we did. It's a much longer story than that. I like to boil things down because I'm a simple-minded person. We can make this change if we build social, political, and economic power and a critical mass of our communities. This work is largely local and regional. It doesn't, thankfully, have to contend as much with the current administration and some of the just inane silliness that's happening in Washington, D.C. We can change the narrative about who belongs. We did that in California, and it has profoundly changed policy. And then finally, we can change policies and build out an ecosystem of health protective policies, primarily that impact low-income people and families that have to navigate these conditions on a day-in, day-out basis at the local level. So I'm a very optimistic person. We can make this change. We've demonstrated it in California. I like to joke sometimes. I say, hi, my name's Tony. I'm from California, which means I'm from the future. What you see in California today, you'll see in the United States tomorrow. So find a way to hold on to hope, to stories that are actually working, and we can collectively make the kind of change that's critical to eliminating health disparities.
Thank you. I'm going to pose a sort of question, but to borrow from the three questions that were raised by Ms. Carlton earlier, and then open it up if we have time. And partly what I've heard from all of you is your own journey to this stage today and what brought you here. And with that, your own understanding and perspective on where we are and how we need to move forward. And the three questions that we were asked were, what must we build? What must we protect? And what must we do together that we can't do alone? And you've touched on this somewhat, but if you could try to be explicit and think about it in terms of these multi-levels, be it the individual, be it the community, be it the organization. How do we build, protect, and not act alone?
Okay, so if I had recommendations, I would say we need to, I'd rather say fortify than build, because I think generations before us have built a lot of the infrastructure, but we need to fortify the infrastructure of that multi-generational community and network that we have. I would say protect community intellectual rights. I've seen some ways where we've sort of, as the intellectuals of our society, have become that not coveted, talented 10th, where we've taken a lot of the intellectual power into the academy, into ivory towers, and not really make sure we shared the wealth of that recognition and those resources with the communities that we've derived that knowledge from. And they really do have the solutions. I mean, I'm from South Central, but I ain't been to South Central in a minute. So the level of knowledge I have is going to be limited to my proximity to this toxic ivory tower that I'm in. So we always have to sort of share intellectual rights, share power, share community with the spaces that we descend from and spaces we don't descend from. And what was the last one? Build, protect, and together? Do science together. Like I don't want to do science with these people I work with. I really don't. I really don't want to do it with them. I want to do it with us. You know what I'm saying? Like when I go to Baltimore and I partner with my community partners, I'm building the infrastructure. Like here's your research coordinator, or we signed a data use agreement with the research partner so that the data is owned by them, and we have to then ask for rights to that data to analyze it. Like we need to do stuff differently if we want to stop being in proximity to the people who are the problem.
They're so powerful. Thank you. And I love these questions. I'm going to try to map them on to one of the ways that I think about leading with humanity that has 3 important steps. I would say stand up, stand back, and stand by. So what must we build together? We have to stand up. We have to claim and own our own voices. We have to make a stand. We have to come up with a shared set of principles and core values that are non-negotiable. We have to hold on to our language and our voices, and what we've built, we need to maintain and sustain. Even when it comes to our lexicon, which is grounded in empirical science, not being so willing to have anticipatory obedience, and instead to maintain a sense of moral clarity and scientific rigor and integrity in that regard. So standing up and continuing to build in that way as freedom fighters. Standing back, developing others, meaning amplifying and uplifting others' voices. You know, let go of the need to try to prove ourselves as the smartest person in the room, so to speak. Stand back in that regard, and in that way, we do protect the more vulnerable because we honor and uplift their strength and their power. And then what can we do together? Just standing by. What did they say? You don't have to get ready if you stay ready. So there are always opportunities to intervene. If someone calls and says, I need help, find a way to help. What kind of resources can we offer to one another in order to continue to move forward this emancipatory work and create a society in which we can all thrive and flourish, because that's what we deserve in our own humanity and in honoring and respecting the humanity of everyone else, particularly that of Black people in the United States today.
Thank you. Well, just to build on those comments, what I would say build that hasn't already been shared is, or complementing, build the capacity of organizations that are in our communities that have ideas, that have answers, to be able to be sustainable and to be able to perpetuate those things. Often, if they're grant funded, they have to keep coming up with new ideas to do things to study new things that are coming out, as opposed to, you know, perpetuating and sustaining the things that they've already demonstrated that work. So if we can build their ability to actually do the things that they know work and that have come out of their communities, then I think that would actually be helpful. Protect, I would say, honestly, protect a sense of hope. Protect a sense that there's actually something we can do. I've seen a lot of folks, particularly in the last year and a half, be quite despondent about the situation that we're in and hopeless. And I think we need to retain a sense that we've been, you know, struggling is a Black Person's Tuesday. I mean, this is what we do, you know. So I think it is just, you know, I think you can help people see we've dealt with things before. This isn't the worst things that we've seen, as much as we tend to, in academia, we tend to think of it that way. But I'm like, we survived slavery, segregation. I mean, I'm hard pressed to say, I get this is rough, but I look at what my parents, ancestors, and so forth dealt with. I'm hard pressed to say this is the worst that we've had it. So I think we have to be careful about that. Build together, I think, is the capacity for creating well-being. I think we underutilize and underfocus on what are people actually trying to be healthy for. It's usually not because they don't want to upset their doctors when they go see them. They want to be healthy because they're trying to do things that, you know, allow them to have impact on their loved ones. They want to be able to have be able to have the energy to spend time with their children and actually not just be falling asleep. They don't want to be exhausted when they get home from work. They want to have, you know, fruitful relationships with partners and so forth. They want to be able to spend their energy expressing love and compassion for the communities that they are part of and that they have that they serve. We don't tend to think about the things that people are striving for as fuel for what we need to build and how we need to anchor that in the aspirations that we have. We're not aspiring to be healthy, we aspire to be well. We aspire to live the American dream of life, liberty, and the pursuit of happiness. And we have a unique way of struggling through that, but we nonetheless have that goal. So I think it is thinking about what those aspirations are and building our collective vision for those kinds of things that matter, that give us hope and purpose and anchor us in love.
I love what my colleagues have said. What I would add is that I think America is in a crisis of existential proportions. I think America has lost its soul, if it ever really had one. And I don't think it's unique to America. I think it's happening throughout the Western world, and I think that's a real crisis. I'll point out that, you know, the health of white Americans is not good. It's actually quite bad, and it's so bad that a lot of disparities researchers don't even use whites as a benchmark anymore. It's really just not a good enough number. You're better off using immigrant Latinos or immigrant Asians or immigrant anyone. Every immigrant group to this country, including immigrant Africans compared to African Americans, have better health than their native-born peers. And the crazy thing is, as they become more American, their health gets worse. America is not good for your health. And so we're in a spiritual crisis in this country with AI and you know, TikTok, and people don't really know who we are anymore. And so I think we need a new politics. We need a movement that sort of reclaims the soul of what America is and what it stands for. And I think that there's no community better situated to lead that movement than African Americans. We historically have held this country accountable to its democracy over and over and over again. And it needs to be a different movement. It needs to be a multiracial movement. It needs to be a multi-generational movement. But it needs to be a movement like the civil rights movement was, which made a demand for belonging. And we need to reiterate that demand because we're living in a world where power and leadership is trying to erase African Americans. So that's what we need to build. We need to build a multi-generational, multiracial movement to reclaim the soul of this country and to create a new democracy. What do we need to protect? I think we need to protect the legacy of African American leadership. Again, African Americans are responsible for the quality, the limited quality of democracy we have in this country. We have held this country accountable. Without us, this country would have skidded off the rails a long time ago. And we need to tell that story, remind people of what we have done to hold this country accountable and to build the tenets of our democracy to date. That's absolutely critical. We forget that story all the time, and many people are actively trying to erase that story. So we need to protect that legacy of African American leadership and commitment to a true democracy. And then finally, what was the last one again? Together. Oh, together. I think we have to get the diagnosis right about what health disparities are. We're still living in a world where people are kind of reflexively falling into a narrative that it's about behaviors. It's the smoking, the drinking, the driving without the seatbelt, and it's not fundamentally the conditions that people have to navigate every single day of their lives. And that is a treacherous narrative because it points directly back to the victim. And I think we have to work together to get the diagnosis right. These are political problems, small p political. Again, I'm not talking about partisan politics. I'm talking about people's ability to participate. And this conference is about justice and equity. Justice is fundamentally about repairing wrongs. Equity is about people's ability to participate in shaping the future. And it's really, really critical that we recognize that our health disparities are a product of people not being able to fundamentally, fully participate in our democracy. And we know how to do that. And if any population knows how to do that better than anybody else, it's African Americans.
I want to thank our four speakers for their comments and their reflections and their suggestions for moving forward. This session is built on something that is just so fundamental to us as we talk about coordinating and working together and collective agency. And we began with this Montague Cobb to Rodney Hood to Dennis to NMA to Cobb to Benjamin, and this history of us leading from one to the next and not forgetting from whence we came. I want to add to this, and I have to do this. My background is in pediatrics and child psychiatry, and we've talked about this collective coming together, but we cannot forget our youth. They must be a part of this. They are the futures to be up here. So as I think about this and I turn this over, I want each of us to think about what I can do. This is not about her or him or they. This is what I can do. But then move from what I can do to what we should do. This is very much about how we collectively move forward, how we're a part of the process, a part of the solution, a part of the future. We keep us and ourselves on focus. And Dr. Benjamin talked about speaking truth to power. We must never forget that we have power. If we had no power, none of us would be sitting up here today. And so remembering those who came before to open a space for us and how it is our job to help prepare for the tomorrow. Please join me again in thanking our speakers for today.
Ladies and gentlemen, that has been an extraordinary program. I've been to a couple of concerts over the past week, and so I would say that if we could stand in a standing ovation for Lionel Richie, we could stand in a standing ovation for this panel. Thank you. And speaking of standing ovations, I'm introducing now the 126th President of the National Medical Association, Dr. Roger Mitchell, for our summation.
The word says on Micah 6:8, He has told you, O man, what is good, and what does the Lord require of you? but to do justice, to love kindness, and to walk humbly before your God. He requires us to do justice, not to talk about justice, not to write about justice, not just to think about justice, not to pontificate about justice, not to be upset about injustice, but he calls us to do justice. To bring kindness, but do it with a humility. I think he was talking about the NMA. I think he was talking about what has just been talked to you today. We heard from Ms. Carlton about a lasting change, a leadership collective, a collective action. We heard from Sir Dr. Cato Lorenzen about the round table of black men and women and our imposition upon the National Academies of Science, Engineering, and Medicine. We heard from Dr. Georges Benjamin about our rightful place in the resistance. We heard from our panel about the pathophysiological response to racism, the importance of black leadership incubators, the importance of partnerships in black men's health. This is a time. It's not a time to feel good about what we're doing, pat ourselves on the back and think that's enough. It's a time for us to realize that this is an upper room moment. Y'all just get to do it watching the Puerto Rico breeze, eating big shrimp. God has blessed you in a way to allow for you to relax, de-stress, and understand your assignment for when you leave here. Oh yes, I'm melodramatic. But I'm a forensic pathologist. I see failed policy on my autopsy tables. What we're talking about now shows up every single day on a cold slab, and they look like you and me. Someone said it's time to take the gloves off. And let me tell you something, there are allies from all races, genders, creeds, backgrounds that are waiting for us to take our gloves off. And they will stand beside us, they will stand with us, they will stand behind us, they will fund us, they want us to do the work because they've been waiting for us to lead in our own struggle. And what is clear is that it's not yesterday's struggle. It's no longer yesterday's struggle. It is today's struggle. It's today's assignment. It's the work of now. And what better people that black men and women, physician, scientists, what better people to tell the truth about a nation? What better people than you and me? Oh, there's a such thing as anger against evil. It's called righteous indignation. And so don't apologize for it. Because in fact, your patients, your community, and this nation is waiting for you to be upset about what is happening today. So, It's Sunday. I don't know why I came up here and did all that. That was not the plan. It absolutely wasn't. But I often find that it's better to be obedient than faithful. So that's all I'm asking you to do, is say yes. That's all I'm asking you to do. Is make a decision today that you won't take anything less than the truth. Under any circumstances. In any of your disciplines, under any of your assignments, with any of your corporate jobs that you have, in any environment, you'll say, no, you know what, we're not doing that today. It has to stop sometime. And so, just be encouraged. I'm so encouraged by Dr. Montague Cobb. I really wanted to come up here and tell you how I love Montague Cobb and how we named a street after him in Washington, D.C., and how I want to be like him too, and all that stuff. I wanted to say all that, but something came over me. Maybe it was neuroplasticity that hit me. The fact that racism can give me Alzheimer's disease. But we need that research, because if that's the truth, if we have cognitive decline because not only the epigenetics of the past, but the current state of our racist stress in our growth through the 80 years that we live, and somehow we have more Alzheimer's because of racism, then we need to know that, don't we? So I'm going to stop, because I'm a preacher, you see that. And it's Sunday, I'm getting ready for next Sunday. I gotta preach next Sunday. I'm so excited. Listen, I love you all. Please give a round of applause for all of our panelists. A better round of applause for Randall Morgan. Please stand to your feet. One of my mentors, one of my touchstones. Y'all are whack. Y'all need to say something. Thank you so much. There's so much more going on. Again, if you want to learn how this organization runs, please come to the House of Delegates. That's where several of us are going, so you can hear how we govern. But then there's other things that are happening. I'll give a shameless plug. We're doing a program that overlaps with the Montague Cobb a little bit, but we are doing a Hip Hop for Life conversation with Curtis Blow and Chubb Rock in the exhibit hall on Tuesday from 10:15 to 11:15, talking about cardiovascular disease. God bless y'all.